our online education subcommittee chairman, who unfortunately cannot attend today. I'm Dr. Pang Hong Wu. I'm the MC of today. I would like to invite everybody and welcome everybody on board of this very exciting APSS Third Advanced Spine Webinar 2023 series. It happened to be the last series in December, 2 weeks before Christmas. I wish everybody a happy new year. And it will be conducted on Zoom meeting and Ortho TV relay. Our webinar theme for today is Craniovertebral Junction and C1-2. Welcome everybody. And without further ado, I would like to invite our president of APSS, Professor Kwan Keong, to deliver the address. Professor Kwan, please. Prof. Kwan, can you on the mic?
Yeah, thank you, Dr. Pang, for a nice introduction.
And C1-2.
So, first of all,
and without further ado, I would like to invite our president of APSS, Professor Kwan Keong, to deliver the address. Professor Kwan, please. It must be the Ortho TV showing the sound. Can someone coordinate that? Can you on the mic?
Yeah, thank you, Dr. Pang, for a nice introduction.
And C1-2.
So, first of all,
and without further ado, I would like to invite.
Thank you, Dr. Pang, for introduction. First of all, I welcome all the participants, the speakers, the moderators, as well as case presenter. So this is the last webinar of the 6 webinars that we have organized this year. So APSS is very committed in terms of education as well as providing research, all right, to all the people or surgeons around this region. So today's webinars is specially designed to address a very difficult topic on craniocervical as well as C1, C2 region. So I'd like to take this opportunity to thank the speakers, Professor Hai Yong, Loya Wong, Dr. Kshitij, the case presenter, Dr. Lim from Malaysia, and Choudhary, as well as the moderator. Also, thanks to online education committee who are working very hard to make all these nice program webinars in the last 1 year. Thanks to our industry partner, MEDTRONIC, all right, for making this our educational event possible. And lastly, to all the participants here, welcome, and I hope that you enjoy this webinar session.
Thank you, Professor Kwan. So today's program, we will have applied anatomy and biomechanics of CV Junction to start off with by Professor Hai. Thank you, Professor.
Yes. Good afternoon, everyone. This is Hai from Beijing, China. I would like to share my presentation, Applying Anatomy and the Biomechanics of Cervical Vertebral Junction. And cervical vertebral junction, also known as the craniocervical junction, it is the first junction of the spine column connecting the cranium to the spine by the base of the occiput, the atlas, and the axis, and the 2 joints that they form, the atlanto-occipital and atlanto-axial joints. Starting from the occipital bone and its contribution to the cervical junction, and the clavicula anterior provides the horizontal support of the pons with its slope ending posteriorly and inferiorly, forming the anterior border of the foramen magnum, also known as the basin. The atlas, also known as C1, is the vertebra It is the ring-shaped bone comprised of anterior arch and its anterior tubercle, two lateral masses, and a posterior arch with its posterior tubercle, as well as two transverse processes. Each of the transverse process hosts a foramen transforming through which the vertebral artery courses. The axis, or C2, is the second cervical vertebrae and is also unique in its structure. It is composed of a vertebral body, the odontal process, facets, and articular surfaces. The pars interarticulus lamina and a large bifid spinal process. The odontal occiput and the odontoaxial joints are paired synomal joints. They account for significant flexibility of the head and the neck movement. Almost over 50% of the flexion and extension are with actuation of the joints. The joint orientation indicates the direction of motion. The odontal occiput joint is a cup-like in the coronal and the sagittal plane. This allows for flexion and extension and explain why little actual rotation occur at the joint. Examination of the normal CVJ range of motion in a modern in vitro biomechanics study suggests that it involves coupled motions, with translation accompanying all primary motion in the sagittal, coronal, and axial plane. While direct of the motion is dedicated by the anterior occiput and the axial joint orientation, the biomechanical stability is determined by the complex ligaments to extent muscular attachment, which are less understood than the ligament function contribute to CVJ stability. A simple way to understand the anterior ligament anatomy is to compartmentalize it in layers. Just posterior to the rectus complement anterior muscle, the most anterior layer consists of the anterior atlanto-occipital membrane, which spans the surface to the anterior arch of atlas. The second layer, which is posterior to the first and in the same plane as the odontal process, consists of apical and alar ligaments. Posterior to odontal process, the third layer consists of the crucial ligament complex, comprising the transverse atlantal ligaments as well as superior and inferior corema. The fourth layer, which is the deepest and the most posterior, consists of the pectoral membrane, which is the cranial continuation of the posterior ligament immediately posterior to that in the dura. The cervical vertebral junction ligament can be functionally divided into vertical and horizontal group. There are several joints involved in this section. One is the atlanto-occiput joint, the joint of the occiput condyla and the superior articular process of the lateral mass of the atlas. The odontoaxial joint, there's the four synovial joints, medial atlanto-axial joint, two medial ones on the front and the back of the dens, and the lateral axial joints, paired lateral ones between the opposing articular facet on the lateral mass of the atlas antithesis. There are many layers of the muscle in this region. It's superficial layer, deep suboccipital muscles layer, and a deep suboccipital layer. In this region, there are also many important arteries and the nerves. The nerve and the artery are very important in this region when you management of this important regions. Normally, the artery is to come out at the C2, at the vertebra, and it goes into the brain. Consider the biomechanics of the cranial vertebral junction. We need to realize some junction. The spinal motion in this section is coupled multi-direction movement. In C's occiput to C1, the flexion extension is about 25 degrees. The rotation is 5 degrees, and the lateral bending less is only 5 degrees. In C1-2, the flex extension is 20 degrees, and the rotation is very much bigger. It's 40 degrees, and the 5 degrees is for the lateral bending. This is the center of the rotation in different region. In the occiput to C1, the rotation is in the center of the C1, and the lateral bending is in the C2, and also the flex extension is in the occiput and C1. Normally, we are using the helical axis of the motion, the three-dimensional analog of the intertenuous center of the rotation, to evaluate the stability of the joint. If the joint movement is pure rotation without translation, all intertenuous axis in the central cord will concede. If the orientation of the line of the helical axis motion is parallel, the rotation is true. When access the mechanics of the injury of this section, there will be several things we needed to discuss. The injury to the odontoaxial complex may be described using the concept of a major injury vector, representing a summary of the most important and applied to the spine and causing the injury in question. A diagram of spinal anatomy with a major vector surprise provides an easily understand the description of the mechanism of injury. Some common injury to this section are illustrated here. A naturally aligned axial compressed major injury factor associated normally with the 4 parts fracture of C1. Another name is the Jefferson fracture, associated with occipitocondylar fracture in several times. And the posterior position axial compressed MIV will associate with the fractures of the posterior ring of C1 near the vertebral artery. So this is very important because sometimes the vertebral artery will be injured after this mechanism of the injury. And the MIV of the Hammond's fracture has a significant bending component. The C2 often appear in conjunction with the C1 fractures. Once the variant angle of the FIP occurred, it can provide type 1, type 2, and type 3 odontoid fractures. And also, if the FIV is anteriorly directed, the transverse of ligament of C1, C2 will be occurred. It can be ligament injury, and it can be also with the intact. The MRI showing on the left is the injured transverse ligament, and on the right is intact of transverse ligament. And if the rotation force was involved, there will be a significant torque component causing rotational subluxation of the C1 and the C2. Here was 2 cases showing the mechanics of injury in the CVJ. The first one is a male, 30 years old. He has the car accident presenting with a paraplegia in the C1-2 level. You can see there's a odonto-occiput dissociation showing on the A sagittal and the parasagittal CT image showing elevated basin dense interval, as well as anterior dislocation of the occipitocondylar relative to the lateral mass of C1 consists with anterior occiput dissociation. And the C and the D is the MRI image showing that segment disruption of all the ligaments of the craniovertebral junction, as well as the capsule alento-occiput joint ligaments. And the E is demonstration demonstrating the modified candela C1 interval and an accurate method to diagnosis of AOD. And 4, the patient had a surgery, posterior fixation from the occiput to C4, and resulting complete recovery of the nerve injury. The second case is a 37 female with a car accident and showing bilateral condyle fractures. And on the ACBD, the CT image showing bilateral condyle fractures extend into the basin. And note that the anterior occiput joint is intact. And on the image EGFH, the CT image obtained after 3 months of bracing of this injury, showing healing of the fractures. In conclusion, the craniovertebral junction compromised the atlas, axis, occiput, and associated joints. Understanding its applied anatomy and biomechanics is crucial for addressing specific disorder or injury affect this region. The key points include the unique structures. The CVJ has distinct anatomical feature that differentiates it from the subaxial cervical spine, housing vital neural structures. The component involves in atlas, axis, occiput, allanto-occiput, and allanto-axial joints, forming a complex and intricate structure. The biomechanical characteristics exhibit complex biomechanical trends, a coupled motion, and 50% of the cervical motion, influencing its stability and function. Lastly, it has significant clinical relevance. Understanding the regional anatomy and the biomechanics aids in managing disorders affecting the craniovertebral junction. And comprehensive understanding the applied anatomy and the biomechanics of this junction is vital for understanding its unique structure, function, and clinical implications. Thank you.
Thank you, Dr. Yong Hai, for your informative lecture on anatomy of CV junction. Next, I would like to call upon Dr. Kshitij Choudhary for his lecture on CV junction pathologies and its management strategy. Dr. Kshitij.
Can you hear me? Hello?
We can hear you, Dr. Kshitij. Please go on.
Thank you very much. I'm in place of Dr. Sudhir Srivastav, who is my professor and teacher and the president-elect of Association of Spine Surgeons of India. And it's an honor to be here. I'm going to tell you a bit about our philosophy and management strategies for CVJ pathology. The problem of CVJ pathologies is the sheer breadth of pathology that can lead to problems in this region. And this can be very confusing if you see each pathology separately. In fact, CVJ management strategies are very debatable and many surgeons may not agree on the treatment plan for these problems. It is also true that there may be more than one way of dealing with a problem. So in the next 10 minutes, I'm going to give you my view on how we manage these problems. As suggested by Dr. Dominic Thompson from Great Ormond Street, I like to view CVJ pathologies through the biomechanical lens rather than a pathological one. We all know that clinical features often are the result of one of 3 biomechanical abnormalities we see in this region, namely instability, deformity, and spinal cord compression. And patients usually have a combination of these 3. Down syndrome is an example of instability. There is no deformity there. Congenital basilar invagination is an example of deformity. There may be some instability, but predominantly it's a deformity issue. Achondroplasia with foramen magnum stenosis is an example of pure spinal cord compression. And this is a rare situation, as in most pathologies, the spinal cord compression will be as a result of either instability or deformity or both. So whenever I see a craniovertebral problem, I try to think which of these three biomechanical issues need addressing when treating a particular problem. And as a bird's eye view, the management strategies for each biomechanical problem can be summarized like this. For instability, the diagnosis on dynamic imaging and the treatment is to stabilize. For deformity, the distortion of bony anatomy is best judged on a fine-cut CT, and the primary treatment is reduction of the deformity. And for compression, the treatment is decompression. This is an example of Down syndrome requiring stabilization of C1, C2. This is a deformity in congenital basilar invagination that requires deformity correction. And this is an example of Chiari malformation with stenosis requiring decompression. Coming to imaging of patients with predominantly an instability issue. The investigation is some kind of dynamic imaging, commonly X-rays, but sometimes in small kids with dysplasia, it is difficult to judge on X-ray the instability. So dynamic MRIs are useful in those situations. For imaging of craniovertebral deformity, the deformity has to be closely looked using a fine-cut CT. We use multiplanar reformatting of DICOM images to understand cross-sectional anatomy and have also used 3D modeling softwares like 3D Slicer to simulate screw trajectories. We are looking closely at the lateral pillars that cause the deformity. Those are the major weight-bearing columns and have to be either destroyed or deformed to cause a deformity. We measure the amount of distortion of the joints by using the sagittal joint inclination angle as proposed by Dr. Sarath Chandra. And it is the inclination of the C1, C2 joint with respect to the posterior aspect of the odontoid process. We also measure the cervicomedullary angle and the clival canal angle. And our goal of surgery is to restore this to an obtuse 135-degree plus angle. We also like the PBC2 measurement, which tells you how much the odontoid is behind the line joining the basion and the posterior inferior corner of C2. And our reduction goal is to reduce this to less than 9 millimeters. And in the coronal plane and the axial plane, it is also important to assess the rotational component of the deformity. The next step is to evaluate reducibility if the patient has a deformity that is not correctable on dynamic imaging. For that, we use intraoperative traction under general anesthesia with full muscle paralysis to assess reducibility. And we have used weights up to 1/4 of the body weight of the patient for about 15 minutes or so to judge how much of the C2 reduces from its vertically translocated position. Some deformities, in spite of sustained traction, will not show reduction or will have partial reduction. Those we will classify as irreducible. And when I mean irreducible, I mean that we anticipate some extra surgery, like a release procedure that is going to be required to make it reducible. And the way we define that is that we see the relationship of the odontoid with respect to the clival line, which is easy to identify intraop and can be used as a proxy to determine where the basion is. And if the odontoid tip is above this line, then a release procedure is going to be required. Coming to treatment strategies. Those patients with a predominantly instability issue that is apparent on dynamic imaging that reduces on extension requires a stabilization procedure. For example, rheumatoid arthritis with AAD, done a transarticular screw. For a Down syndrome kid with the C1, C2 and OC1 instability, occipitocervical fixation. For os odontoideum, again C1, C2 harms fusion. Tuberculosis causing a transverse ligament disruption, not much bone damage, causing AAD fusion with a transarticular screw. Again, tuberculosis with a structural damage to the odontoid process. Primary issue is instability caused by the fracture or a destroyed odontoid process. Surgery is C1, C2 fusion. Coming to the other side of the equation where the deformities that do not reduce on dynamic imaging, for those a CT scan will show the status of the lateral pillars and the facet joints. And the ones without a fusion of the facets, which is 99% of the cases, we will use an intraoperative traction under general anesthesia. Those that reduce on traction are treated with posterior fixation without a release, and those that cannot be reduced require a release operation. This is an example of basilar impression in tuberculosis where the lateral pillars are destroyed. The deformity is not reducible on flexion extension X-rays, but reducible on traction. No release is required. Correction is on implants and achieved intraop. Similar with rheumatoid arthritis basilar impression. And again, this is an example of a reducible congenital basilar invagination. Flexion extension X-rays does not show reduction, but traction X-rays do. And no release procedure has been done. And the reduction is on the implants and traction as described by Dr. Abumi. And this is the post-operative MRI. For those patients who do not reduce on traction in operating room, there are two options for release for making a reducible deformity reducible. A posterior release that is described by Dr. Goyal initially and later expanded by Dr. Sarat Chandra, or an anterior release as proposed by Dr. Wong from China. And I think there is a place for both these procedures, and the way we decide that which one to use is by looking carefully at the C1-C2 joints. And my preference when selecting a procedure depends on how deformed the C1-C2 joints are. If the sagittal joint inclination is less than 100 degrees, then I would choose a posterior joint distraction technique of Dr. Goyal and Sarat Chandra. It works quite well. But the angles for larger ones, like say between 100 and 160, I think it depends on other factors. But in this range, we start thinking more of an anterior release over a posterior surgery, increasingly so when we have a patient that is closer to 160 degree than 100 degrees. And when the sagittal joint inclination is more than 160 degree, I think posterior release gives suboptimal results in our hands and it gets technically quite difficult. In this example, you'll see a partial reduction using DCER for a case where sagittal joint inclination was more than 160 degrees. For these situations, we prefer an anterior release as we doubt the ability of extra-articular distraction of the joints with a disarticulation to correct the deformity to a satisfactory extent. This is a technically difficult operation, while anterior release is not only technically less demanding, but a perfect realignment is reassured. So this is an example of a patient with less than 100-degree joint inclination where a distraction works quite well. This is another example of rheumatoid arthritis. Joint inclination is not bad, where a Goyal's procedure has worked well. But this is an example of a congenital deformity where you see the sagittal joint inclination is almost vertical, about 180 degrees. And in this situation, that is quite difficult. We uniformly use a transoral, sometimes a retropharyngeal approach to do an anterior release, followed by a posterior instrumentation. The posterior instrumentation technique is similar to what was described by Dr. Abumi, but the anterior release is more or less similar to what was described by Dr. Wong. So this is an example of a patient more than 160-degree inclination with this kind of a reduction that can be achieved. This is a 17-year-old boy, KF syndrome. This is preoperative imaging. And look at these intraoperative C-arm pictures. The first image is traction before release. You can see the location of the odontoid with respect to the clival line. This position is after release. In the supine position, you can see the odontoid has come down significantly just because of the release. Then we have turned the patient position prone in traction. And then when you apply posterior thumb pressure on the C2 spinous process, the entire odontoid moves forward with respect to the clival line. And this is how you get a post-operative reduction, complete reduction, not only of the vertical dislocation of the odontoid, but also the retroversion of the odontoid, which is so important to reciprocate the correction of the subaxial cervical lordosis post-operatively. So this is what can be achieved. And interestingly, when you see post-operative CT scans, you can see the distraction of the facet joints like this. This is a CT scan post-operative reconstruction that you can see how much reduction can happen with an anterior release. And you can even do it in a revision scenario where a patient has been fixed in an abnormal position. You can still do a transoral release and a posterior reduction to get a correct alignment. So to conclude, I think it's best to look at CVJ pathologies from a biomechanical viewpoint. For instabilities, you stabilize. For deformities, you reduce. For compressions, you decompress. For irreducible deformities that don't reduce on traction with full anesthesia and muscle paralysis, some kind of release is required, either anterior or posterior. For those with low sagittal joint inclination, a posterior release works quite well in our hands. But for high joint inclination angles, an anterior release and a posterior fixation, the Wong's procedure gives a very good result. Thank you very much.
Thank you, Dr. Kshitij, for your excellent lecture on CVJ junction pathologies. Now we would like to have a Q&A session for the last two talks before we go ahead. So right now I see no questions, but I have a question for Dr. Yong Hai. Sir, any note on vertebral artery anomalies and whether do you see that preoperatively? Dr. Yong.
Yes, normally we will evaluate the patient with CT image, MRI, and also sometimes we will do the MRI of the cervical artery. And there's a slight chance of the high rising of artery of the patient. In that time during the procedure, you needed to pay extreme attention to the region to avoid any vertebral artery injury during the procedure. And for the posterior procedure, it's extremely important for that if the condition occurs. And I haven't had any experience of the intraoperative artery injury, but from the literature, this happens from time to time. And it can be very dangerous. And because in the elder people, especially for the rheumatoid arthritis of the problem, and the soft tissue condition in this region is not very good. So sometimes you will have a stroke of the brain and leave some very severe complications. Thank you.
Can I have a question for Dr. Kshitij, Choudhary? For after you do an anterior release, how do you maintain the release before we turn patient over for instrumentation?
Yeah, so that is a very important point that you bring up, and it's a very good question. Because when we started doing this, we were worried about this problem because the anterior release makes the C1, C2 area very, very unstable. So what we do is that when we are doing a transoral release, first of all, we are doing it under SSCP because you can't do an MEP when you are doing an open mouth. And then once that thing is over, we activate the MEPs and the traction is still maintained, and the surgeon with 4 other people maintain traction while turning the patient prone. So you cannot let go of the traction when you are turning the patient prone. And I think initially we were concerned that this would be a very dangerous maneuver to do. But in the last 15 years or so, while we have been doing this, we have had a problem only in the first case because we did not anticipate how much release would cause instability at that area, and we turned the patient in the usual fashion, and we had a clinical deterioration in neurology in our first case. But after that, I do the prone positioning myself. I don't allow fellows or residents to touch it, and I'll constantly keep a very strong traction on the cervical tongs while we are turning. So we have not had a problem, but yes, it's a concern, and I make sure all my team members, including the anesthesia, are on hyper alert. I tell anesthesia that we don't want low blood pressures. This is a dangerous maneuver that we are doing. We want everybody in the room. And we have more than enough people to kind of do that flip. Yes, very crucial.
Thank you.
I have a question to Dr. Kshitij.
Yes.
Yeah, Kshitij, I just want to ask you about Dr. Patkar's technique, what he does, that anterior release and distraction with that Ellis plate for
Right.
basilar invagination. What is your
So as I said in that slide of mine, I think it works quite well. But it works quite well only if you have two conditions satisfied. It works well if you have a relatively lower sagittal joint inclination. For really those very vertical joints, that is a compromised operation, right? Because it's very difficult to get in distraction from the front. Maybe it is easy to get the soft tissue release and the distraction, but to keep it apart is not easy.
Yeah.
Right. And then the implants from the front are biomechanically not as strong as what you do from the back. So the more severe the deformity, more the angulation, just doing standalone anterior is a problem. A standalone anterior is okay for, say, less than 100-degree sagittal joint inclination, good bone, and you have really the third generation or the fourth generation anterior plating. Because if you use those standard platings, those are not really good.
Okay, thank you.
So we can introduce our next speaker. So may I please call upon the president-elect of APSS, Dr. Yatwa Wong, to give his talk on effective management of traumatic CV junction affection tips and tricks. Dr. Wong.
Sure. Thank you very much, Chair. Do you see my presentation in presentation mode?
Yes, we can.
Okay. Good afternoon, everybody. My talk is on cervical vertebral junction trauma. Cervical craniocervical junction consists of osteoligamentous structure that accommodate spinal cord, vertebral artery, and need to support the head and also allow a great range of movement. Apart from X-ray and CT scan, MRI is very useful to evaluate the status of the ligamentous injury as well as the C2-3 disc. For unconscious patient, I have a very low threshold for MRI examination. Sometimes CT angiogram may be necessary. Odontoid fracture is the most common fracture in this region, and combination of fracture is also not uncommon. Both type 2 and type 3 fracture are unstable. Both of them can be treated non-operatively or operatively. However, type 2 fracture is associated with high non-union weight, and that's why it is further subclassified into A, B, C. A, minimal displacement. B, the fracture configuration is favorable for odontoid screw fixation. And then type C has comminution, or the fracture line is in an acute angle with the odontoid screw. Therefore, if surgery is contemplated, we may need to do posterior fusion rather than odontoid fixation. Type 1 fracture by itself is not significant, but it may be a sign of avulsion fracture of the ada ligament. Therefore, we should exclude craniocervical dissociation until proven otherwise. Type 2 fracture has a higher non-union weight. That's why it is relatively indicated for surgical intervention. For type 3 fracture, I personally is in favor of halo-west immobilization because it can preserve the C1-2 movement in long term. For the odontoid screw insertion, I like to use 2 X-ray machines so that we can save time in flipping the X-ray machine to get the lateral and the AP view. The mouth is kept open by radiolucent bulb so that the jaw and the teeth do not obscure the X-ray view of the odontoid process. I use the Mayfield skull to control the head and neck alignment so that the odontoid fracture is reduced for the screw insertion. Normally, the incision site is over C5-6, and then at the pivotal plane, we can develop up to C2-3 for the screw insertion. in my locality, because of the small size of our patient in general, I can only insert one screw, but I still insert two guide wires. One is to guide the screw insertion, and then another guide wire is to prevent spinning of the dents. I always tap the whole screw thread across the fracture site so that when the screw is inserted, it will not push the odontoid process away from the fracture. For the hangman fracture, type 1 has minimal displacement. Type 2 displacement more than 3 mm, and it is thought due to the hyperextension injury followed by fascial injury, and that's why there may be some disruption of the C2-3 joint, and it is associated with CV anterosuperior corner body fracture. There is a distinct type of type 2, type 2A. It is associated with severe angulation, and the mechanism of injury is different. It's by fascial distraction injury. There will be more angulation at the C2-3 joint, and it is quite unstable, although ALL may be intact. And we should avoid traction because it can increase the kyphotic deformity. Type 3, the peculiar feature is subluxation, is the dislocation of the bilateral C2-3 facet joint, leading to very severe C2-3 spondylolisthesis. This fracture is very, very unstable and absolutely indicated for surgery. Type 1 fracture can be treated non-operatively with high fusion rate. Type 2A and type 3, surgical operation is preferred, no matter it is an anterior C2-3 fusion or a posterior fusion. Type 2 fracture is in the middle. We can treat conservatively by halo west immobilization or operatively. We can discuss with the patient the surgical option. If we can insert the C2 pass screw securely, then we don't need to extend to C1 and preserve the C1-2 motion. Some surgeons advocate osteosynthesis. However, to me, I think it is difficult to find suitable candidate for this procedure. Since type 1 fracture, they don't need surgery. For type 2 fracture, the C2-3 disc is injured, and I don't know the long-term effect if it is not fixed. The occipital cervical dissociation is a deadly disease. Most victims die before they arrive in the hospital. It consists of a wide range of ligamental injury, ranging from isolated ligament rupture to a complete dissociation. However, a lower GCS and a delay in diagnosis is associated with higher mortality. So keep a high index of suspicion and intervene early to prevent mortality. There are a lot of radiological parameters to confirm the diagnosis, such as more than 8 mm Bayesian dense interval, Powers ratio more than 0.9, distraction between the occipital atlantic interval more than 2 mm, or the odontoid process go posterior to the Wickenham's line. And abnormal parameter confirm the diagnosis, but normal time, a normal measurement doesn't exclude the diagnosis, and therefore MRI is very valuable in confirming the diagnosis. Some surgeons recommend intraoperative gentle traction to test whether there is any more than 2 mm displacement between the occiput and the atlas. Although the dissociation is between the skull and C1, but normally we will do occiput C2 fusion because most of the stabilizing ligament end at C2. Some patients are associated with multiple injury and hemodynamically not stable. And I find that if we need a temporary fixation or we need to do other operation for life-saving procedures, the quickest operation is to fix the occiput to C2 lamina, and we can do it within less than 1 hour. Transverse ligament rupture can be in the middle, avulsed from the insertion, or in association with the Jefferson fracture. If the total C1 lateral mass displacement is more than 6.9, it confirms the diagnosis. Although less than 6.9, it cannot exclude the diagnosis. The management depends on the integrity of the transverse ligament for the Jefferson fracture. If the transverse ligament is intact, we can treat the patient non-operatively. If it is ruptured, most of the time C1-2 fusion is necessary. Some surgeons also recommend direct osteosynthesis. That can be done from the front or from the back. And also, some surgeons extend the indication to bony avulsion of the transverse ligament. In my opinion, the success of hospital C1-2 instrumentation depends on adequate exposure and control of the venous beating. I normally coagulate before the beating starts. And if the beating starts, it is sometimes difficult to control the beating. And then I pack the beating site with the hemostatic agent. And also in trauma, because of the associated ligamental injury, the bony fragment can be very mobile. So we need to stabilize the bone by a bone cam before we drill the screw trap. And sometimes I will use a cutting burr to prepare at least part of the screw trap before using the drill. For the C1 lateral mass screw insertion, my landmark is the medial side of the lateral mass. If the posterior wing is big enough, I can insert the screw directly through the base of the posterior wing so that we save the dissection of the venous passage between the C1-2 lateral masses. But if it is small, then we have no choice but expose the C1 lateral mass for direct screw insertion, and the sagittal alignment will rely on the X-ray control. Although there may be chance for injury the C2 nerve root and the patient complain of occipital pain and numbness, but even we sacrifice the whole C2 nerve root, only 10 to 20% of the patient has sensory deficits. For the C2 pedicle screw insertion, my landmark is the superior and the medial surface of the pars. The insertion site is about 2 millimeters lateral to the mid pars 9, and as dorsal as possible, but not perforating the superior surface. C1-2 transarticular screw fixation also offer very good stability. However, 30% of the patient, they have high riding vertebral artery, making the insertion of the transarticular screw impossible. And the landmark is still the medial side of the pars. And the sagittal alignment is aiming to the middle of the anterior arch or the superior one half. Since not all patients, we can insert the pedicle screw because of the anatomical restriction, small pedicle or high riding vertebral artery, we need contingency plan. One is C2 pars screw. The insertion is similar to transarticular screw, but not go through any cortex. And then another contingency plan is C2 laminar screw. Since the screw is tangential to the spinal canal, and the external wall of the lamina can serve as a guideline. So it can be inserted freehand and easy. Although the laminar screw is not as strong as the pedicle screw, it provides reasonable stability for the C1-2 fusion. For the occipital screw, we know that midline has thicker bone, especially towards the external occipital protuberance. The rule of thumb is to insert the screw as near the external occipital protuberance as possible, but without causing any skin impingement. C1-2 canal is quite wide. So even in screw malposition, spinal cord injury is not common. In my opinion, the vertebral artery is in a greater danger. And as you can see, the cortical bone around the spinal canal is thicker. So perforation into the spinal canal is less common. So if I'm in doubt I probably will converge the school a little bit rather than putting the school in a diverged position. In terms of the avoidance of the VA artery injury, during the exposure, I think two locations we have to be careful. One is on the superior surface of the lateral C1 wing. When we encounter the depression, it may be the bony groove for the vertebral artery. And then from this intraoperative photo, you can see how close the vertebral artery near the lateral edge of the C2 lateral mass. So when we approach these two regions, we should try to avoid the use of monopolar diaphragm, and superiosteal stripping to expose the bone is relatively safe. We also need to recognize the anatomical variation, the conspicuous posticus, because the vertebral artery are embedded in bone. And if we insert the C1 lateral muscle screw through the wing, it may directly hit the vertebral artery. However, most unilateral vertebral artery injury, patients don't have any clinical consequences. But we need to be aware that bilateral vertebral artery injury can be fatal. So if we injure one vertebral artery, no need to be panicked, but we may need to change the surgical plan to avoid any chance of injury the contralateral vertebral artery. So thank you very much for listening my presentation.
Thank you, Dr. Wong. I see no question in chat. So if I can ask one question, do you use wiring commonly in C1-2, if at all, especially like what are your indications, and do you commonly use wiring now? Any special scenario?
Very uncommon, but I occasionally use wiring in a few conditions. One is if somehow, I mean, last few years, I encountered a case of a vertebral artery injury on one side. So I use wire on the other side. I mean, that was quite a long time ago. And then another incident of vertebral artery injury, because I now can use the laminar screw. So I think that is an alternative. And then the third case I encounter using the wire is a patient with very thin bone at the occiput. Although nowadays we usually use screw and pay for the occipital fixation, but that particular patient was a osteogenesis imperfecta patient. The skull somehow is very thin, so even a very small screw, very small short screw, I cannot insert it securely. So I use wire to tie the rod to the occiput. I think those are the cases that I encounter using wiring.
Yeah, Professor Wong, very nice presentation. Just for benefit of our younger colleagues, can you just tell us what special precautions or tips for any prevention of vertebral artery injury? Investigations, what all things are important, which is must for you, and if it happens, what is the strategy if you see a vertebral artery injury on table, what one should do?
As I mentioned, unilateral vertebral artery injury, patients are usually all right. The chance of having a cerebrovascular incident depends on which literature you are referring to, around 5%. So in fact, no need to be panicked. And then continue the operation. Very important. The contralateral side, we need to be very careful. So choose a technique, there's no chance to injure the vertebral artery. Now that is the first thing. Now the second thing is whether it is necessary to do a intraoperative arteriogram. I'm not 100% sure, but inside the operation theater, in the orthopedic operation theater, it's difficult. And radiologists or even the neurosurgeon, they prefer not to do it. So after the operation, we can subject the patient to the angio suite for the angiography. And if necessary, they can do standing or embolization. I think that is the only experience I have. One case, eventually the neurosurgeon and the radiologist, they do a standing after a vertebral artery injury. I do not have a big series to tell what should be the most appropriate treatment effort. Perhaps the other speaker or faculty can share your experience.
Thank you. Thank you, Professor.
Dr. Abumi is not available due to some health reasons. So can we, if we have no further questions, can we go for case-based discussion?
Yeah, so Dr. Lim Han Sim from Malaysia to start the first presentation. Dr. Lim, please.
Good afternoon, everyone. I would like to share my screen first. Okay, good afternoon. This is my first case. This is a case of the 31-year-old female have a MVA 3 months ago, and he have multiple fractures and admitted to the hospitals. However, he treated conservatively. At the same time, he complained of the mild pain over the neck and pain over neck. She underwent the CT scan. CT scan shows some minimal lateral C1, C2 interval unequal, and the ADI is normal. And you can see there's a left side, there's some minimal subluxation, not the significant subluxation of C1, C2. So we treated patient with a collar. 1 month after that, patient come to follow up. He showed that mild torticollis and neck pain. But during that time, patient not keen for any intervention, and MRI that was done that time, although it's that time, and the patient defaulted follow-up after that. And then after 3 months of the NVA, patient starting show up again. He told us that he have the torticollis is progressive worsening, and the neck pain also worsening until she unable to sleep and move. However, there's no weakness, numbness, and myelopathy symptom. On examination, patient have torticollis with the face still to the left and in severe pain, and patients still have normal gait, no neurological deficit, and no myelopathy sign. This is the current is the X-ray on the presentation after 3 months of the MBA. You can see that the patient have torticollis with the left tip to the left side, with the face tip to the left side, and loss of C1, C2 lordosis. However, we are unable to perform any flexion extension view in view the patient in a severe pain. This is a CT scan of the patient. You can see patient have the ADI is 1.7 millimeter. The power ratio is within normal range. However, there's we noted there's severe unequal of the C1, C2 lateral ADI, and also have atlantoaxial rotatory dislocation with the joint also deformed. However, there's no others like retropharyngeal abscess and thing. And this is a 3D recon of the patient, and it showed that there's a lateral inclination about 10 degrees and deform of the lateral right side C1, C2 facet. So if according to this EC classification would be the grade 2. This is an MRI of the patient, C1, C2 facet deformed, and we don't appreciate any transverse ligament torn, but there's a capsular ligament laxity. The left C1, C2 facet ligament loosening. There's no cord edema or stenosis. This is a finish of the case presentation. Any question from the floor?
Please stop it here so that we can take opinion of other speakers.
Yeah, thank you.
Dr. Wong, would you like to say something? Please share the screen, Dr. Lim. Please share your screen.
Yes, I think the diagnosis of this case is traumatic rotary subluxation at the very beginning.
Yes.
And since the initial CT scan already shows some asymmetry, to me, if an MRI was done at that time, it may be able to pick up some ligamental injury. that is why in my talk, I repeatedly emphasize my threshold for MR examination is very low nowadays. That's one thing. The second thing is now already be 3 months after the injury, the soft tissue may have been scarred down. But having said that, since this is not a bony deformity, it's soft tissue deformity, I think the patient may respond to skull traction. So I will put the patient on halo traction for some time, gradually increase the weight, and the maximum weight can be increased up to half of the body weight if the patient can tolerate. But at any stage, if the alignment is acceptable, we may put the patient in a halo and hoping that we can save the C1-2 fusion. But eventually, if this cannot be done, we encounter similar case, and then we even keep the patient in a opposite deformity and keep the patient in such a position for some time, see whether we can save the C1-2 fusion or not. But if the patient had recurrent rotary subluxation, then I think the recommended I will eventually recommend a C1-2 fusion. I think that is my opinion. Thank you very much, Dr. Lim.
Thank you, Prof. Wong.
Dr. Kshitij, are you with us?
Yes.
Yeah,
so it's very interesting. I agree with the previous opinion, because here it comes down to what is the intactness of the transverse ligament. And if the transverse ligament is intact, you would at least want to think whether this can be treated without a fusion. So if it reduces on traction, then you will have to maintain it in that position in a halo vest for about 2 months, 3 months, until it heals in that position, provided the transverse ligament is intact. But if not, then I would kind of also consider like a release procedure from the front, a transoral release procedure from the front, let it align in traction and hold it in a halo in that position, and see how things heal by 3 months. And at the end of it, if the patient still has an anterior posterior instability, then think of doing a C1-C2 fusion. So in that sequence, probably it gives the patient a little bit opportunity to maybe not do a fusion at that level. But everything depends on how the transverse ligament is going to be. I'll still at least consider that option, that do a release, align the C1-C2, keep it immobilized, see how things go, maybe get more advanced imaging, a thin cut MRI at that level, a really high resolution MRI to see how the transverse ligament is, and then take a call.
Yes, so Dr. Lim,
Yes.
you can probably go ahead and Dr. Shailesh, would you like to comment something?
No, I think I agree. Probably I will be more conservative in this, but if at all, anterior release and maybe a posterior halo will be a good option.
Yeah.
Okay. Thank you for all the opinion. I will share one. So what I do is we do a posterior instrumentation and fusion of our C1-C2 under intraoperative pneumomonitoring. We put on the C1 lateral mass and C2 pedicle screws, and we preserve the C2 nerve root. Because of the we didn't do attractions, and intraoperatively it unable to reduce, so we expose and explore the C1 lateral C1-C2 facet, and we release it, do a posterior release and reduce. We unburr the joint and we put a rod. This is what we done. This is a pre-op and post-op X-ray.
So what intraoperative difficulties did you encounter? Was it reducible easily or not?
Initially, during the exposure is difficult because it's irreducible because without tractions. So, but we put our patient on Matthew clamp. We try to release the posterior capsule, the capsule joint, and then we reduce it by using some small instrument like this McDonald or the small size of the peri in between the C1, C2 joint to lever up joint, and the lever up joint, and also so that we can reduce the C1, C2.
Okay. Anyone wants to ask other panelists? Would you like to say something? Yes, sir.
Vijay, may I ask?
Yeah, please go ahead.
Prof. Wong? Yes,
May I ask
Prof.
two
Wong?
questions? I mean,
Yes.
one is after the surgery, the neck
yes.
seems still tilted to the left. May I know the reasons behind? And secondly, I don't have experience in doing the anterior release. I just want to ask other speaker. I think for the fixed rotary subluxation, do you think a posterior release alone can how high is the chance that can correct a very fixed soft tissue rotary subluxation?
But I think for my case, because I think the C1, C2 still not really fully restored to the fully anterior. I think maybe the right side C1, C2 joint already reformed. When you reduce, also you're unable to go to the previous shape, because after 3 months, maybe the right side of C1, C2 joint already deformed a bit, so it dropped down a bit. So even we reduce to the normal position, however, we're still unable to fully restore the previous state. I feel that.
So can I answer that, the other part of release?
Yes.
So I think the outcome is good, but it's just when you are doing a posterior release, I think you are committed to doing a fusion, because
yes,
the way you will pull the C1 lateral mass behind is with a screw. So one option is to do kind of an intraoperative fixation, but not a fusion, and then later remove the implant, so that it's like kind of a putting in a halo device, but just like on the bone, that you are immobilizing it in the correct alignment, letting the soft tissues heal, don't do the fusion, and then do an implant exit. Now, many people have published this for odontoid fractures, and they have shown that it can still maintain the rotatory movement, but for this particular pathology, whether it will work or not, I'm not really sure. So when it comes to rotatory subluxation, the fusion, I think, absolutely mandatory only if your transverse ligament is gone. Otherwise, there is a potential that you may not fuse this situation. With an anterior release, it gives you that option. That's the only thing. With a posterior, you will have to pull the lateral mass with a screw. You won't be able to push the one that is behind, but you'll have to pull the one that has gone forward behind with a lateral mass screw. So and then again, it will be the posterior release always will be a compromise, like in your experience it was a little bit partial in terms of getting a posterior release and correction, whereas anterior release would ensure that it would be corrected.
Yeah,
Thank
very
you.
good insight. Yeah, I just have one question. Did you pack any graft in the facet joint, or did you use a spacer or anything like that?
We didn't use a spacer. We burr the lateral facet, the C1, C2 facet. We burr it to make sure the fusion C1, C2 joint, and pack the book. Yeah.
Okay, thank you. So I think there are no further questions. We can go for the next case presentation by Dr. Shailesh.
Yeah. I'm just trying to share my screen.
Yeah.
Is my screen seen?
Yes, it is seen, well seen.
Yeah. Thank you, APSS team and Dr. Vishal for giving this opportunity. We'll start with the case. This was a 52-year-old patient who had an accident and he was operated elsewhere with this anterior and posterior surgery in 4 years back, in 2020. And this gentleman presents to us again with a two-wheeler accident and he sustains C2 fracture and quadriparesis. He was having grip weakness, abduction weakness, lower limb weakness, and there was clonus. When he was presented, this is his MRI with the old decompression, which was adequate, and fixation was good. And the latest one, which shows displaced and retropulse dense type 2 fracture. And this was the MR angio. I'll just go back again to all the images. This is the X-ray with the previous surgery, front and back, which was done elsewhere. And this is the second fall from two-wheeler. And he was given some conservative treatment in a local hospital from which he was shifted to us. Or with clonus. And this was his MRI. With CV junction compression.
Yeah, so
with instability. Yeah.
we can just stop it here if we can.
Yeah.
Yeah. Dr. Wong, your esteemed opinion on this case.
First of all, I want to ask a question. Whether the odontoid fracture is a new fracture or an old fracture left behind due to the first injury?
He was doing everything like a normal person post first surgery, and this was a fresh fracture.
Now, the second thing is there is a lot of periodontoid shadow from the MRI. So I'm not sure whether this patient has some pre-existing osteoarthritis between the odontoid process and C1 anterior arch, or the patient has a congenitally small C1 spinal canal. If you go back to the MRI, so there is a, from the MRI, we can see a periodontoid mass that I think it compromises the AP diameter of the spinal canal. I think that the reason for me to ask the first question, whether it is a new or old fracture, is that if it is a fresh fracture, odontoid screw fixation may be one of the treatment. But this one, since the spinal canal is also quite small, and with the periodontoid mass, even the fracture configuration is favorable and is a fresh fracture. I probably will do posterior decompression to enlarge the spinal canal and fix the C1-2.
Okay. And Dr. Kshitij, what's your take on this case of high cervical myelopathy?
For this case, again, from a biomechanical point of view, this is an instability. So I think this would be like a reduction from posterior approach and fusion. I agree with the previous comment that this doesn't look an acute fracture. This looks like a chronic fracture. There are a lot of bony changes around that odontoid fracture. You can see on the CT scan. Can you put up the CT scan?
Yeah.
And if you magnify, you can see that on the posterior aspect, there is some flake of bone forming. Even anteriorly, it looks as if there is some stabilization happening from the anterior arch to the C2 vertebral body. So I think this probably may be related to his first accident, and then this is kind of a new. And also the other thing, the MRI, can you go back to the MRI? And the MRI does not show any like edema there. You would imagine if there is like an acute fracture, there would be prevertebral, some kind of hyperintensity, a collection or something there. But this looks quite quiet. Even the bone marrow edema doesn't look like that of a fracture. So I agree with the previous comment that this would be kind of a extended indication to do an anterior odontoid screw for this patient. So my choice would still be posterior C1 C2 fusion.
Dr. Lim, can we have your take on this, as we have some time left? So Dr. Lim, would you like to say something?
For this case, look like a chronic fractures. I feel that this patient have this basilar. The fracture look like going to the like some basilar invagination. I will do from posterior, and I would like to do the still. See, yeah.
So, Dr. Shailesh, sorry, can you can show what was done.
Yeah. So we did all posterior, and we did decompression as well. And luckily we have the navigation and arm that really is useful. Probably this is what everyone has said is right. Probably there was an old injury, and this fall precipitated the injury. And we did C1, C2.
Now inserting C1. So you can see this is the end of this.
You can play the video. We have enough time, Dr. Shailesh.
I have a video. Can I just?
Yeah, you can play the video. I think we have.
The video is there now?
No, the screen seems to be.
Okay, I'm just yeah.
Are you sharing screen or are you sharing PowerPoint?
I'm just trying to share the screen, yeah.
Okay.
I'll have to stop share and then switch on the new one. Is it seen now? Can you see the screen? No? It is seen with me here, but I'll just get back in 30 seconds. Yeah.
So, sir, Dr. Wong, we would like to know your experience, how about navigation? At present do you use navigation at your center for C1-2 cases?
We have navigation, but I rely on my surgical dissection and the exposure of the anatomical landmark for the upper cervical screw insertion. So I don't have experience on the navigation.
Yeah, so now that you have done both, what is your take? Does navigation really help in such scenario, or it's just fad, or what's your take? Now that you have done open for a very long time and slowly shifted to navigation in some cases, do you think it helps in difficult cases?
Certainly, if there is deformity, especially, then the anatomical landmark may not be that reliable. But for the usual cases, I think on anatomical landmark is equally good.
Okay.
And also, from my limited experience in using the navigation in this region, I'm not sure whether this is others' experience or not in C1-2, because they are very mobile. So using navigation, the error may be a bit high, or we may need to register the image from time to time, unless you have intraoperative CT. So perhaps the other can elaborate more on this point.
I think we also felt it. We are using it for nearly 4 years, but we don't need to re-register, because once you fix it at a good point, most of the times we can actually get away. And once you have done open surgeries, I think navigation is a big advantage, because you are seeing everything in front of your eyes, and you will not have a misbeat while doing this surgery. I think once we started doing this, it has become a routine for us, and even doing cervical pedicle screws, it has become a absolutely great advantage. Like a big brother is watching us, and we are just there in front of it. That really makes it very easy and useful for an experienced surgeon. The video is getting downloaded. Just maybe half 30 seconds.
I can show a case still if you want.
Yes, please go ahead, Dr. Kshitij. That'll be interesting.
So it's not prepared as a PPT, but I'll just show you this. Can you see this screen?
Yeah, you can
just make it full screen.
Yeah.
Here.
Okay.
So this patient had is an 8-year-old boy, myelopathic, about a month or two, no neck pain, some torticollis, difficulty walking. You see he has myelopathy. This is his picture. Then you can see this is his sagittal images. And then this is his lateral views. I think that was my last slide. I showed you the almost vertical angles of the C1, C2 junction, but you can see the vertebral artery right here in front of the joint. So, doing a posterior access to this joint and drilling this joint from the back, you'll have to deal with the vertebral artery there. So this is his just clinical pictures. These are his multiplanar formatting for the C2 screws, how they would go. This is for the for the opposite side. But the laminar screws look good. You can see how thick the laminar bone is, where the C2 and C3 is actually fused to in a single posterior element. That's why the lamina looks quite good. So just as a pre-op evaluation in your mind that, this would be a good place to put the screw in. This is how the CT angio looks from the front. You can see almost kissing internal carotid arteries from the front because of the shortening that has happened at the craniovertebral junction. And this is just what I would like to show you, that how the 3D modeling helps, where segmentation helps us create all these models, but you can see the vertebral artery right in front of the joints. And let's say for this patient, if you're doing a posterior procedure only, then you will have to deal with these vertebral arteries, which are right in front of the joint. So this is how it looks from the back. So I'll just stop here and maybe we can discuss how, the others would kind of take an approach towards this problem.
Dr. Wong, we would like to know any special caveat while you deal with pediatric subluxations, pediatric cranial subluxation.
In the meantime, I'll just show you how the traction X-ray looks like. This is how the traction X-ray looks like. So this is traction of about 4-5 kilograms. With the full muscle paralysis, patient is in general anesthesia, and we generally have stopped doing preoperative traction for these patients. In the past, we were doing preoperative tractions for, like, say, 2-3 days prior to surgery. I don't know how many of you still try to do that on the floor when the patient is awake, and whether it has made a difference. We have found that it has not made much of a difference. So we have kind of stopped doing preoperative tractions. Is there any opinion on how do you judge reductions for these deformities?
Kshitij, I fully agree with you. I think this one is because of the bony deformity. So preoperative traction probably won't work too much. And secondly, if I'm managing this case, I probably will, like what you do, we also have a 3D printing support. So I think it is very good to have 3D printing, at least the software, so that we can play around and understand the anatomy, especially the course of the vertebral artery. And then it clearly shown that there is no C1 wing, or the C1 wing already fused with the base of the occiput. So and the aim of the surgery for this particular patient is to decompress the brainstem and pull the odontoid process out. So, but honestly speaking, I mean, that is not my specialty. I probably will work with the neurosurgeon to plan for the anterior decompression plus minus release, and then we can work on the posterior fixation. That is quite routine for us. And then for the posterior surgery, it really depends on whether I can find a window to insert the screw. Otherwise, I can dissect out the vertebral artery, and then if the vertebral artery is dissected out, then inserting the screw is not an issue. So eventually, after the anterior release decompression, we will do the posterior occipital cervical fusion. I think that is some idea in my mind.
So yeah, it's very good point. So we have found that, doing this this way, preoperative 3D analysis of the anatomy with a modeling technique, irrespective of whether you use navigation or you don't use navigation, if you spend enough time studying the anatomy preoperatively this way, you become really confident about this area when you are exposing for this patient. I would literally spend 3-4 hours before the surgery doing this. And when the surgery when I am operating this, I feel so confident that I know this anatomy like at the back of my hand. So I, again, like you, have not used navigation in this area. We use 3D printed model guides for like really difficult situations. But if you know where the vertebral artery is, the C2 pedicle screw is a really easy screw to put. So the issue becomes like, subaxial pedicle screws in the C3 and C4, where you have, a little bit less wiggle room there. But like in this model, you can see that I have made the surface of the model a little bit transparent. So you can see the vertebral artery, how it courses in the V1 segment in the bone. And obviously this is a 3D model, so you can rotate it and move it around and see how the vertebral artery is and where is going to be that bony part where you would be able to put that screw. And then we take like this is a 4mm tube that we have created on a computer model. And then you just play around like a video game and try to put it where you want to put it. And you at the end would get something like this, that, okay, I would be able to put 2 laminar screws this way and a 1 pedicle screw this way to get fixation enough in this bone. And then plan the kind of surgery that way. So just to go ahead, this was how we kind of gave traction to this patient for a while, and then the transoral exposure. So the interesting thing is to look at these intraoperative C-arm pictures on how the release changes the alignment. And when we first did this surgery with my professor, Dr. Lahiri, we were really surprised as to the power of the release in correcting the deformity. So you can see this is a supine traction. This is the picture with thumb pressure. So I put like my hand behind on the C2 spinous process and I'm trying to push the C2 ahead. But still most of the odontoid is behind this clival line. Now we have found that if you don't, it's very difficult to assess reductions on lateral C-arms because the mastoid air cells and the petrous bone all overlaps that area. So you don't really have a good judgment of where the basion is because the C1 arch is assimilated. You really don't know where the foramen magnum is at the base of the skull. So if you don't see the pituitary fossa, you won't be able to see the clivus. And then if you extrapolate that line, you are really able to judge how the odontoid is with respect to the foramen magnum. So the moment you draw that clival line, you can imagine where the foramen magnum would be. So here, if you see, the odontoid is right in the middle of the foramen magnum if you extrapolate this line. And this is like, the exposure from the front. And then I'll just go ahead. And then this is where my upper extent of exposure is there from the front with the forceps. And then this is after removal of the fused anterior C1 arch. Then I take a small curette just to see where the tip of the odontoid process is. So here you can see the tip of the curette is on the tip of the odontoid process. So that means that my vertical extent of release is quite good. And then you see, compare the before release under traction photo C-arm with the after release under traction photograph. So you see the odontoid station has come down quite a bit. Odontoid has moved quite a bit. So there's significant improvement here. And then if you see the foramen magnum is going to be here and the odontoid is quite anterior to it. And then this is supine position without the thumb pressure. But when you give the thumb pressure from behind, the whole odontoid translates forward to a significant extent. If you see here and here, the difference. So I like that thumb pressure maneuver as well. And then we discussed how we carefully turn the patient prone. And then again, the photographs of in traction prone position without thumb pressure and the other with the thumb pressure. And that thumb pressure gives you a good idea about how the cantilever forces of the implant is going to correct this deformity. So here the screws put according to the plan, C2 pedicle screws and 2 laminar screws. And when I look at this instability here, it is quite severe instability because there is so much distraction there that you can't really hold this whole column on just few screws. You will have to put multiple screws, and at least at least 2 pedicle screws or 1 pedicle screw, 2 laminar screws, because this will not work with par screws or just.
Dr. Kshitij, Dr. M.K. Kwan also wants to present a case. So
Okay, so I'll just go to the last part. So this is without the cantilever maneuver. So the rods are off, and then we just approximated the rods on the plate, and then that's the correction. So here you can see this is the correction technique. You keep the rods long, compress it. I guess all posterior surgeons do this way. In addition to the anterior release, it gives you a good outcome. So
any X-ray you have, like post-op X-ray?
oh yeah, so my screen is a little frozen. Let me see. It's not scrolling. Just let me see. I'll show you it back again. So that's the final fixation. This is the final fixation.
Yeah.
And it's important to appreciate how the cervical lordosis changes, because unless you get the odontoid in the correct alignment or restore the lordosis in that area, you won't get cervical lordosis. It is like fixing L5-S1 spondyloptosis in a kyphotic angle and then expecting the lumbar spine to behave properly. And this is exactly what is happening in the craniovertebral area, just exactly reverse in the reverse manner.
Yeah, thank you, Dr. Kshitij. That was a nice case presentation.
Should I show the video? It's ready, I think.
Can we do one thing, like let Dr. Kwan present the case and we'll keep the video as the final thing. Is that okay, Dr. Shailesh?
Yeah, that's okay. That should be fine.
Yeah, so can I please invite Dr. Kwan, who's the president of APSS?
Hi, thank you, Loya. Since we have time, so let me share a case as well. So can you see the slide?
Yes, we can see your slides.
Okay, so just to summarize it, 62 years old female, chief complaint is neck pain for 2 years, and severe right upper limb radicular pain and numbness for 1 year, which is progressively worsening. So neurologically, it's normal. Reflexes, normal. No myopathic spine, sign surprising. So these are X-rays of the patient. As you can see, there is a dislocation, subluxation over C1, C2. This is a CT scan and MRI of the patient. So at this point, the diagnosis is alontoaxial instability due to os odontium was made. So a management was to perform skeletal traction with skull tong. We performed 8 kilos, total traction of 6-week duration. And post-traction, 3 weeks, as you can see, the dislocation have reduced to become subluxation, and 6-week fully reduced. A CT scan was performed during this process, and what we have found is that on the right side, the C2 pass, the size is good for a pass screws, whereas on the left side, you can see there's a high riding vessel. And please take note that the angiogram show that on the left side, the CT angio, all right, evidence that the vertebral artery is a major vessel on the high riding side on the left side. Assessment of the C1 show that on the right side, the posterior arc was not in connection to the lateral mass of C1 on the right side. Whereas on the left side, the C1 posterior arc are in connecting to the lateral mass, but very thin. So the discussion now is, what are the options available? Are we still going to do C1, C2 fixation for this patient after reduction? Or other options.
Can we pick the brains of other panelists?
Kwan, may I ask one question first?
Yes.
Was your CT scan done after the reduction, after the skeletal traction, or before the traction?
This was halfway during the
So
traction.
Now, because after your reduction, the C1-2 relationship may change after the complete reduction. So
Yes.
I'm not sure, at least on the right side, if the relationship change, there may be more option. But nevertheless, because the left side is the dominant vertebral artery, and if it is high riding, it's difficult to put the transarticular screw. And how about the pedicle size?
The pedicle size for which level?
On the left side.
Left side is on right side is good.
C2.
The left side is bad, as you can see here. I'm showing you the slides now.
I mean, how does it, how is there any room medial to the vertebral artery?
No.
It's a converging screw.
No. It's a very high riding dominant vessels.
And then how does the, like the 3D posterior surface look like? Like, do you have a volume rendered image?
Yeah. I don't have the image, but practically it's impossible for you to put a vessel there. And in you is the dominant vessel, it's a major vessel.
Right.
You wouldn't want to try that.
No, I was looking at how the posterior arch of C1 is.
Now I'm showing you posterior arch of C1. On the left side, the posterior arch is intact, whereas right side, the posterior arch the connecting portion of the posterior arch to the lateral mass is absent.
I think you've got a very good reduction with a very prolonged traction. So I think it's still possible to put C1 lateral mass screws even if you don't have a posterior arch on that side. That side is the less dominant vertebral artery, and you can reach the posterior arch by sacrificing the C2 ganglion and walk over the C2 dorsal surface of pars and reach, even if you don't have a posterior arch. I think C1 screws are possible. C2 screws are going to be tricky. So
yes.
then
so
it
what
is
are the options that we have?
screws. Yeah. Laminar screws possible? Would it work? You'll have to see the
Yes.
image of laminar screw.
I think laminar screw is possible.
So, I mean, I am quite okay to do a C1, C2 with laminar screws in the C2 and lateral mass screws in C1.
Yeah, a good option.
Yeah.
Yeah.
Doctor,
Any other?
Yeah.
Yeah.
Yeah, Dr. Adgaonkar, would you like to say something?
The only thing is sometimes, like, just because you have got a very good reduction, that laminar screw and the C1 lateral mass screw will work quite well. But let's say if you are going to manipulate on laminar screws and C1 lateral mass screws because you don't have a reduction, then it gets really tricky because the laminar screw tulip and the C1 lateral mass tulip is not in the same line. And then if you want to do any manipulations of the dislocation, it becomes quite tricky in those situations. So if you have got a good reduction, then that kind of a construct is less of a hassle. But I don't know what your experience is. Like, for example, the first case that we saw, the rotatory subluxation. In those cases, if you try to do laminar screws and C1 lateral mass screws and try to manipulate that in line, will become very tricky because they are not in the same kind of plane to
Yes, I agree.
get a connection. Here, I think it will work quite well, maybe.
Yeah.
So I think we can move on, sir.
Well, would you please show the X-ray after reduction?
Yeah, these are
Yes.
X-rays.
I want to bring up another point for discussion. The hospital C1 joint, are they mobile? The C1 seems stuck to the occiput.
Based on the CT scan, it's not fused yet.
Okay.
Yeah.
My point is that sometimes if C1 is very stuck to the occiput, and if they are not very mobile, in fact, if you have difficulty in inserting the C1 lateral muscle screw, may as well go to the occiput. But I do agree with Kshitij. This one probably insertion of the C1 lateral muscle screw is still possible directly
Yes, I
into the
agree.
lateral mass.
Yeah. So in view of time, just let me share with you what I've done. So in this case, so what we have done is left C1 lateral mass, C2 lamina, and right side C1 C2 transarticular screw. So we're connecting all these tulip using a modified connecting rods. And this is X-rays after the surgery. And just to illustrate the point, so we put left C1 lateral mass because there are still a connecting portion between the posterior arc and the lateral mass to guide the screw in. We put a C2 laminar screws on the left side because of the high riding vessel. On the right side, in view that we have difficulty putting a C1 lateral mass screw, we perform a C2 transarticular screw. And we connect all these three tulips using a single rod. So this is post-op 2 years, showing fusion, a solid fusion between the C1, C2. So the take-home message is that C1, C2 fixation is very versatile. We should not fix with an idea that only C1 lateral mass and C2 pedicle screw is the only viable option when we deal with C1, C2 fixation. Instead, that there are many other options available when we come to fixation of C1, C2 region. Yeah, thank you.
Yeah, very good idea. Nice idea.
There was a impromptu case presentation by the president, Dr. Kwan, and it was very interesting. Can Dr. Shailesh, can you just show your video so that we can call it a day for the meeting?
Yeah, I can share.
Yeah.
Is it seen now?
No, we are not able to see. We're just seeing that folder.
Yeah, small picture of the video.
Yeah. Is it seen now?
Not really.
I'm resuming the share.
Maybe you can unshare and reshare only the video.
Yeah, I'm doing that only. Only video I'm trying to do. I'll just take a last attempt.
Or if the video is embedded in your PowerPoint.
No,
you
I've kept it separate. I've kept it separate also. I'm just sharing that. Is it seen now on the screen? All of you?
Sorry, doctor, still we are seeing the same folder. Or is it possible to, play in quick time and yeah, we can see it now.
You can see it now? Yeah.
You can describe in between and Dr. Shailesh, that will be good.
Yeah. So this is the pre-op. Can you see all of you? Yeah.
Yes.
Can you see this?
Yes.
Yeah, we can see
Yeah.
the.
So this part we have already seen, and I'm just going to show the advantage of.
We have time. You can. We have at least that much time. You can just show it slowly and share your thoughts.
Which we have applied at the lower cervical level, and it's quite a strong and stable thing. We don't need to retake any other shoot for the O-arm, and once we check everything, we take the first low dose shoot. This becomes very easy for most of the CV junction cases because anatomy is in front of you and a 3D model is in front of you. It is live, it's real time, and you really can place your lateral mass, your pedicle screws, par screws comfortably. At the same time, it's important to dissect well. It's very important to identify landmarks. It's not that navigation will help on everything. Once you identify, then it becomes easy. And even I have discussed with few guys who are using this navigation. I think the tactile feedback is very, very important. It's not that navigation is giving you everything in front and it's like it's a ready plate for you. It's not like that. It's ultimately that 3D understanding should be there in your mind. You have to study the X-ray, you have to study the CT very well. At least you need to give good time for planning before you do this. And the 3D really helps you. If you see the same procedure is repeated on the other side, and the chance of you having any malposition or misplacement is very, very less. That's the beauty, and everything is in front of you. So I think this is going to be next useful thing for all of us for doing these complex level cases. It makes life very, very easy, and the planning becomes very, very easy, and on table things becomes very, very safe and accurate. That's the right word.
Thank you, Dr. Shailesh. Just would like to ask, out of curiosity, how do you set up like for a C1-2 case? How do you set up the navigation? How different it is from other lumbar or spine?
This basically it is normally on the head side where we are seeing it while doing it, and the O-arm normally it comes and goes. It just 13 seconds a low dose scan and it goes away. So we don't need to really worry about that big machine which is seen initially. It just that. If you're theater, you need to have slightly larger theater for the maneuvering of the O-arm, but otherwise navigation, the still station is just in front of you. Not any special things we need to do for this.
Okay, that's interesting. So any other panelist would like to ask, or any other discussion we have for the day?
Sorry, I'd like to ask Dr. Shailesh, regarding just now you do a C1, C2 fusion, were you, I want to ask the panelists whether you all will connect to the previous construct or not, or just leave it like C1, C2 fusion? Any concern in the stressor in between the two constructs?
Dr. Kwan, would you like to answer the question? Like, would you like to
Yeah. Whether you can connect the construct, again, that is depend on the pre-existing pathology and also the status of the disc in between the two constructs. So I think in cervical, where motion is very crucial, we should preserve at all costs.
Thank you, Prof.
Yeah, any other thoughts by Dr. Wong or any other panelist? Yeah, if none, so I would like to hand over to Dr. Wu Pang to give a vote of thanks.
Thank you, everyone, all the esteemed speakers. It is one of the highlight of the year. This is a very challenging cases, and you really give encouraging results and lots of knowledge exchange. I think it gives confidence to the audience on how we can tackle CVJ as well as C1-2 region complex anatomy as well as complex fracture fixation. Thank you everyone for the wonderful sessions, and we wish everyone a happy new year. There'll be more exciting program in the 2024. Stay tuned for our subcommittee to come up with more programs. Thank you very much.
And just a reminder, the abstract submission is open till 31st December for the APSS meeting, which will be held from 14 to 16 June next year in Hong Kong. So Merry Christmas and Happy New Year, and hope to see you in Hong Kong. So we can call it a day. Thank you so much. Thank you to all panelists.
Thank you, everyone.
Dr. Kwan, Dr.
Yeah.
Wong, Dr. Shaili.
Yeah, thank you, everyone.
Dr.
Thank you, everyone.
Thank you. Thank you, everyone. Thank you. Bye.